I am here to introduce Dr. Rheanna Platt, who will be moderating our next panel and our last panel of the day. Dr. Platt is a child and adolescent psychiatrist and associate professor of psychiatry and behavioral sciences at the Johns Hopkins School of Medicine, but she shares a joint appointment at Bloomberg School of Public Health with us. She's a consultant for Maryland's Child Psychiatry Access Program, which is supporting primary care providers to manage the mental health needs of their patients. Her research focuses on implementation of family-based screening, prevention, and treatment interventions in primary care and in community settings. So, without further ado, Dr. Platt.
Thank you. So I'm really excited to be moderating this panel and mostly to get to hear from the fabulous speakers that we have. So we're just in the last panel talked about sort of broad trends that impact mental health of youth and impact society more broadly, like social media, the rise of AI, climate change, for example, and then some of the resulting challenges like that we talked about. So disconnectedness, lack of empathy, conflict, and these are complex problems, and I think would argue that we need to be thinking about solutions that address those, and many of those are inherently not limited to one sector. So one thread of all of the speakers today is going to be around collaboration across systems and specifically thinking outside of healthcare systems. And so the goal of this panel is really to talk about how we can engage sectors across communities to support and promote youth mental health. And we'll talk a little bit about collaboration, funding, and advocacy across these. And so to start with, Alicia Barnes is the Urban Child Institute Endowed Chair and Associate Professor of Child and Adolescent Psychiatry at the University of Tennessee Health Science Center and serves as the Chief of Psychiatry at Le Bonheur Children's Hospital, where she leads multi-sector mental health initiatives using a system of care approach. She also holds leadership roles as the president of the Tennessee Society of Child and Adolescent Psychiatry and is on the executive council of the American Academy of Child and Adolescent Psychiatry, which all of us came together last week at our annual meeting. And she's going to talk about implementing wraparound approaches for youth mental health. The next person we have, I'm going to go a little. So John Damon is the CEO of Canopy Children's Solutions, which is Mississippi's largest and most comprehensive nonprofit provider of children's behavioral health, education, and family support solutions. John works with all three branches of government, business and thought leaders, and community stakeholders to develop public policy, clinical best practices, and catalytic partnerships aimed at helping every child and family reach their full potential. And he's a fellow of the 5th class of the Health Innovators Fellowship and a member of the Aspen Global Leadership Network. And he's going to talk about scaling mental health services in Mississippi schools. And then we have Tamar Mendelson, who is a Bloomberg Professor of American Health at the Hopkins Bloomberg School of Public Health. She is the director of the Center for Adolescent Health and chair of the Adolescent Health Steering Committee of the Bloomberg American Health Initiative. She's trained as a clinical psychologist, and her work addresses the prevention of mental health issues and promotion of positive development in young people with an emphasis on mindfulness-based interventions. And she's going to talk about school-based interventions for common mental health conditions. And then Sidney Hankerson, who is vice chair and associate professor in the Icahn School of Medicine at Mount Sinai. His research promotes mental health equity by partnering with churches, youth sports leagues, and other trusted community-based organizations. He's a member of the NFL's Behavioral Wellness Committee and a second opinion physician for the NBA, and was recently awarded the 2024 Presidential Lifetime Achievement Service Award by President Joseph Biden. He also received the American Psychiatric Association's Distinguished Service Award for significant contributions to the field of psychiatry in the United States. And he's going to talk about faith-based and sports-based collaborations to support well-being. And then last but not least, Kamillah Wood, who is the clinical lead for strategy and partnerships for the health optimization team at Google. In this role, she drives the execution of the team's missions to build health solutions that work for everyone, everywhere on their own terms. She is also a board director at the Community Builders, a national nonprofit affordable housing developer. She's also a practicing community pediatrician and sees patients nearby at Children's National Hospital in Washington, D.C., and she will be talking about technology for youth mental health. So to begin, we'll have each person just talk a little bit about their work and a little bit of what we alluded to already. Alicia. And folks, you can either come up here or if you prefer to sit down.
Hey, good afternoon. I did not eat the cookie. But I'd like to start standing since it is this afternoon and the last session of today. Thank you for that introduction. I'm a child and adolescent psychiatrist as I serve in my current role. And shortly after finishing training, I began in both a clinical setting, being at a federally qualified health organization, and also seeing children at detention centers. This multi-sector work for me really started to solidify when I saw a child that I saw on a regular basis, monthly, in my outpatient clinic show up in my detention center. And I knew what were the things missing. The mom would often bring in her children and say there's no after-school programs. The school is not responding to the needs of my child. And even though we were an interdisciplinary program, a lot of what was still missing were those after-school programs, the faith-based leaders, and just interacting within their community to find those resources to really take a full wraparound approach in the care of that child and that mother. So that's how I've come to this work. And it led me to Memphis, Tennessee. And a little bit about Memphis, about 35% of our population is under the age of 24. So we're in that heart of adolescence. 25% is under the age of 17, and 10% is that 18 to 24-year-old age range. And so even though we're not technically the global South, we're the American part of the North American South. And so we have some similar demographics. And so I started in Memphis at the Center for Youth Advocacy and Wellbeing, where there's been, under the leadership of Dr. Alta Stewart, where there's 10 years of a system of care approach, working with families, working in the justice system and faith-based systems, and also working across sectors and in our police departments. So in the last year, I've continued and started a new position as Division Director of Child and Adolescent Psychiatry, and I'm working on bringing that work into a children's hospital framework, along with our Department of Psychiatry. Which, if anybody works with children's hospitals, if you want to show of hands, anybody works with children's hospitals? Okay, this is not normal. But the need in this crisis, as we saw earlier today, it's a response to the need of in our city and in our area. So with that in mind, the wraparound approach really provides a public health approach to treating children and their families. One of the things that's really key to that is it's family driven. So we talked about youth voice being at the front table. But even when we have youth engagement, if our parents and our caregivers haven't learned a similar language and skill set, we often find a mismatch and a challenge in actually getting to that next level of engagement and wellness and well-being for that youth, because we haven't brought the family along with for the ride. So it's family driven and youth guided. It also centers a strength-based model and being community driven and looking at what are the natural supports in one's community. whether it's faith-based, whether it's in the school system, sports, athletics, and really engaging those aspects of that child's day-to-day life. The YMCA, and one of the challenges we see currently is in zip codes where there's the most need, we're seeing decrease in services. So those are things that we're continuing to try to support and provide extra natural supports in the community to build. And so currently we partner with our comprehensive community behavioral health center, which has a model that also includes family support specialists or family navigators, which are parents who have gone through the experience of navigating the mental health system for their own child. And then they work as advocates alongside other parents to understand and advocate for the needs of their child in the mental health system, but also in the school system. So I've worked on a team with with family support specialists, and I'll tell you, they translate. They're cultural brokers in a lot of ways. Sometimes families don't feel comfortable telling you, "I can't afford that." I don't know where to go to get that, or transportation is an issue, and the family support specialists fill that gap and oftentimes bring those extra resources into the conversation and kind of make sure that next visit doesn't show up where a resource was missed and we didn't know why, or we're a month behind in treatment when the family is oftentimes finding themselves in trouble with the school system and at risk of expulsion, or not, or at risk of losing their placement in their home or housing. So building that partnership along with the school districts and supporting social emotional learning, working with nonprofits and faith-based organizations, as mentioned earlier. In Memphis, we have Suicide in the Black Church, which is a conference that's been held there for the last 10 years. And so it's not only being in the hospital or in the department, but also being at those events and proximate to what's going on, so that when we talk about it would be a good idea to see a psychiatrist, or we really think this is a part of the having somebody to talk to would be helpful. They know who we are and see us on a regular basis in the community. So with that, we're building out those supports. We also have a community health worker on our team who's a really key part of building those relationships in the community at the school base. And a lot of times it's figuring out who's in different nonprofits, because workforce changes and those soft handoffs sometimes lead to other challenges when making connections that is based on relationships rather than transactions and where somebody is based. One of the things that we really, because otherwise a lot of times the children and their families, they fall through the cracks. And a lot of times the feedback we're getting is, where do we find hope when we can't find these systems? And so by taking the wraparound approach and do it in Memphis, that's where we're trying to build that extra hope back in. So with that, I look forward to the conversation. Thank you.
Sid, but you inspired me. You inspired me. Also from the global South, I thought, but rather the third world country that is Mississippi, right? We've got these now and they're great. It's really fantastic. I also inspired, and I'm going to pick up, even though we didn't plan it, on hope. So thank you for that word. Another Mississippian said, William Faulkner, to understand the world, you must first understand a place like Mississippi. And I think a couple different reasons that I think of when I hear that quote is, one thing that we really like to do is to tell stories. We got a lot of writers and storytellers. And so what I thought I might do is tell a little bit of a story. And the work that we're doing, and some of the solutions that are multi-sectoral that we're really trying to bring forward to bring innovative solutions to very complex and vexing problems. And then the other thing I think about with that quote is that it leverages a strength. All of us in this room today built our lives on what we could do, not what we couldn't do. Kids and families are the same. Like if you were terrible at math, that's why you did what you did, right? So Mississippians, one of the things I've watched is when there is a clarion call to a challenge, they rise to the occasion like no people I've ever seen in my life, whether that's the largest natural disaster in history with Katrina or the largest man-made with BP, oil, or right now in the mental health crisis of our lifetime. I'm watching some pretty amazing things unfold that I never thought would happen. And so I'm excited and I'm hopeful in this way. So let me try to give you a narrative, a story of kind of the work that we are in right now, but I need to give some backdrop before I do the foreground. The backdrop, and it's so great to have some of my fellows from Aspen here, Wisdom and Shami and others that have been part of this narrative, which is pretty special. We're all forced to do this thing called a venture project. And in the venture project, I really wanted to help reimagine how we do mental health care. And I had all these, what I thought were great ideas. And then as would happen in this special group of humans, one of my now best friends in life and forever said, John, man, it's so great what y'all are doing. Y'all served 15,000 kids last year, and that's fair. Why not 150,000? Why not 1.5 million? Why not 150 million? How do we take the high-touch work that you do across all 82 counties as the largest provider for kids in the state, and how do we marry the high-touch with the high-tech such that we can leap kind of over the workforce issues, get more care, more upstream, and not just address the 1 in 5 that have a mental health challenge, but how do we address the 4 in 5 who are at risk for that mental health challenge? And how do we think about a comprehensive approach? And so the short story on that is we all began to hack on this. A lot of us in this special group to say, how might we do something together that kind of became a little bit of a mega venture, all of us working together on a project. And in lots of hack sessions here in DC and in other places with lots of youth at the table, I should add, along every step of the way, including youth that we met with from all across the world in Aspen and different cohort groups to speak into the project and on and on and on. We finally launched and piloted into two in the Madison School District in Mississippi, this what is based on hope. Okay, and so my quick piece, and this is important to understand because I think it's a nice, not front door mental health, but when we're working across systems, sometimes you have to speak language that's palatable to them, because if you come in as the mental health group at the school, they're going like, no. We've watched Illinois, we watched a lot of places where that's not always welcomed. So what we came in with was what we want to do is increase the hope of your children. Because there's over 2,000 published articles, all of us researchers in the room, that say hope is actually the best predictor of a life well lived. That hope, by definition, is, this is Rick Schneider's work, is the belief that your future can be brighter than your past, and, important conjunction, you have the power to make it so. How do you have the power to make it so? By having a clear and compelling goal in your life, something you'll really wake up in the morning for, having multiple pathways to run at that goal, and then the willpower that fuels the path to the and we know that willpower is biologically limited. Who didn't do their workout this morning, right? Probably not doing when you get home. Because willpower is biologically limited, you have to have other people in your life. That's what AA, NA, Weight Watchers, small groups, all that is based on this, so that they become your willpower to run the path to the goal when you don't have it. So we went in, this whole piece was designed for us to then screen for hope, and then triage from green, yellow, red. Those who are yellow, red, yes, we're going to drill down with PHQ-9s and GAD-7s, because you must. But for the rest, which is 4 and 5, We're going to get upstream, holistic wellness intervention that's education around how to do and increase hope in your life. And we put it in 25-week curriculums and blah, 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 and have analog versions of the digital, so everybody's got access. There's all that behind the scenes. We piloted it. It was a huge success. Okay, engagement rates, and I should have mentioned, in addition to screening the kids, we also screened the families for social determinants of health, food insecurities, housing insecurities, job insecurity, and we would wrap teams, we would have them statewide across all 82 counties in those families to work with them to solve those problems so kids get to school ready to go. That screener was a huge success. That all worked, and we were making sure that we educated, supporting the executive branch and the legislative branch and everybody else about this work, so that when the governor knew that he had some leftover COVID funds and CBDG dollars, and he wanted to do something in youth mental health, he says, this would be the perfect thing. And so we made an application through HUD, we're talking about cross section, Housing Urban Development, down to the Mississippi Development Authority, down to the nonprofit, into 29 school districts, $16 million to take to low to moderate income schools. And this is about 40,000 students, and with their families, 80,000 altogether, that will have this entire curriculum on hope that also screens them for mental health without us leaving in the front door going, we're the mental health providers. All right, do we do that? Absolutely. But I think the mindset that we have to have in this moment is to really think about where people are and lean into where schools, educators, housing, economic, job, all of that, and really take the work that we do to those sectors. And that's what we've done. So the teams are rolling that out. It all happens in January. And we had the state superintendent hosted all of the 29 districts that received this. And 24 in one day, in short notice, 24 of the 29 superintendents all showed up personally. And they are nose down, tail up, so thrilled to really run at this very different kind of cross-collaborative solution. And maybe we can unpack more, but that's kind of a quick narrative and story. Thank y'all.
So, everyone looks pretty awake, even though it's that time of the afternoon. I'm really glad to be here, and it's amazing to learn about all this exciting work that's happening on the panel. So most of my work is focused on promoting positive mental health in schools for young people. When I was a teenager, we did not have any kind of mental health person or programming in my school. And now most schools have something. But when you really drill down and sort of see what is that something, it's often very limited. There's data showing that fewer than 3% of schools actually have school-based health centers where there's on-site comprehensive health and mental health support. And in an ideal world, you would really want to have a tiered nested system of supports that looks like a triangle, where the bottom of the triangle are supports and resources for all students. And we can think about that very broadly, including the arts and sports and restorative practices, mindfulness. There are a lot of different kinds of things that we can offer to all students that create a culture and a climate at schools that really sort of acknowledges young people as whole people and really helps to develop all of them and not just sort of their math scores, right? So that is the bottom of the triangle, with the middle being intermediate supports for kids who might have known risk factors. Maybe it's chronic absenteeism, maybe the loss of a parent. And so offering those young people some perhaps pull-out supports, groups, or other ways of helping to prevent mental health issues. And at the tippy top of the triangle, the more specialized and more expensive supports, like one-on-one therapy for young people who may already be showing signs and symptoms of mental disorders. And I think, first I would say, I think this is a really important piece of promoting well-being for young people. But I do really want to highlight that this is just one piece in a much larger puzzle of what needs to happen, with a lot of work that needs to happen on the upstream drivers of the sort of structural oppression that creates so much trauma that is not equally distributed across our young people. So we really need to be thinking also about how do we fix these kinds of traumas and stressors from affecting the mental health of our young people to begin with. But as for schools, I think that they can really help to offer a way of reaching young people. I mean, logistically, that's where young people are most of the time, and or most of them anyway. And in addition, schools are part of the context that young people grow up in that shape them. And so the more we can make the school environment and culture one that truly supports young people as full humans, I think that's a very, very important part of shaping their development. I mean, it's going to shape their development for better or worse, right? So, it's important to think about what happens for kids going through a school day. And if their exposure is to racism or bullying, that's going to have an impact. How can we make that exposure a positive one? And then I think we actually have a lot of evidence-based strategies at each level of the triangle, but we're not using them. Really, very few schools have that sort of nested or tiered structure. And so, some of what I want to touch on is just how can we move to that next stage. And I loved hearing the numbers that you were talking about. They're so big. Like I'm not going to talk about those kinds of numbers, but I think really how do we scale and reach young people in a much broader way. So I'll talk a little bit now about one program that I've worked with almost since I've come to Hopkins, which was a long time ago now. And this work grew out of an initial collaboration of the Center for Adolescent Health at Hopkins with local centers in Baltimore that served young people who had left high school and were getting job training and GED training. And so they identified mental health as an issue that was preventing young people from achieving their goals. And they partnered with us, and the young people, we worked with 9 peer leaders, and they chose a trauma treatment called SPARKS, which stands for Structured Psychotherapy for Adolescents Responding to Chronic Stress. That is a mouthful. They chose that as an intervention that would actually be a good fit for young people in Baltimore who often experience sort of chronic and acute stress over time. And so we worked with them. And we spent many months adapting that intervention from a trauma treatment delivered in a clinic to a prevention program co-led by young people that was delivered at that time in the employment and training program setting. It worked well. We had promising results. The young people liked it. And we started thinking, how can we take this and adapt it, earlier for young people before they leave high school, to help actually with the transition into high school, a positive transition. So then we spent a lot more time working with, we worked with 6th, 7th, and 8th graders. They were like, this is boring. It's, they really, they had us redo a lot of things because we had been working with older adolescents. So it is a very interactive program, 12 sessions. We've delivered it 2 times a week during the school day. And we've worked with principals to find a way to do that. And the program's core components are things that have already been mentioned today. So mindfulness, some cognitive behavioral skills, education about the effects of stress and trauma on the body and the mind. And we continued using young people as co-facilitators, but the members of our study team also were working together with them in the schools, and I'm thrilled we have colleagues here today from the team. So what we found is that in an initial pilot, we found that teachers, this was a small randomized controlled pilot study, and teachers saw improvements in sort of classroom behavior, but also social behavior and emotion regulation in kids who had been in this program versus the controls, even those kids who didn't have symptoms of mental health issues. So this helped us to do a larger randomized controlled trial in 29 Baltimore City schools. We worked with 8th graders at that transition point into high school, and we enrolled close to 650 young people in 8th grade across those schools on a volunteer basis. What we found was that this program, compared to a health education program, improved symptoms of post-traumatic stress disorder, depressive symptoms, anxiety symptoms, and behavior problems. And these, again, were not young people who had been selected for having issues in these areas or had any, known risk factors. We just took all comers. But what we did see after the fact is that close to half of the young people in the study had elevated symptoms of PTSD, and that speaks to a lot of the challenges that young people in Baltimore are facing. At this point, we need to move this more sustainably into schools, and so we've recently gotten a grant that will allow us to test whether having school mental health providers or school personnel without specialized mental health training, which of these are better positioned or can both be effective leaders of this program, and to really start to develop a toolkit for schools that are interested that would give them cost benefit, and sort of a menu of what might be a fit for their school. So we're excited for that work moving forward. Thanks.
Good afternoon, everyone. I said, good afternoon, everyone. All right. It's the afternoon, but in the spirit of tradition of the African-American churches with whom I partner, I thought we'd start with a little call and response. So brief introduction, and then I do have a few slides to show that, funny enough, do talk about hope. And we didn't plan it. So again, by way of introduction, I'm Sidney Hankerson. I'm Vice Chair for Community Engagement and Director of Mental Health Equity Research at the Icahn School of Medicine at Mount Sinai. In that role, I'm really charged with promoting mental health equity across our department. And my journey into mental health equity and to youth specifically started over 15 years ago. I'm an adult psychiatrist by training. So I want to put that out there. And if I could see the first slide, I started into research focusing on mental health disparities through a K Award, which is a training grant that NIH offers to young investigators. And the focus of my study at the time was to train African-American clergy in interpersonal psychotherapy, or brief IPT. So Myrna Wiseman, for those of you who may be familiar with her work, was my primary mentor at Columbia at the time. And we submitted a proposal to train faith leaders how to provide this evidence-based depression intervention for pastors. And a big part of what we did was to create this group as a part of our grant. You see actually Dr. Wiseman seated next to me in that picture. You can tell that picture's a few years ago because I still had hair. But we created, under the guidance of the late Dr. Loretta Jones, who was the former CEO of an organization called Healthy African American Families, and Dr. Ken Wells, who's a psychiatrist at UCLA. I was trained in a methodology called community partnered participatory research. We've heard about CBPR. This is basically CBPR focused on mental health services research. And the key element of community partnered engagement is the formation of a steering council. So the difference between a steering council and a community advisory board, as Dr. Jones told me, is that an advisory board can be ignored. a steering council drives where you want to go. A steering council is rooted in community. And a steering council is fundamentally attuned to addressing the structural factors that led to the disparities that you are trying to address. And so what I love about the formation of this steering council that we created is that you can see the diversity certainly in the picture, but it cut across sectors. So we had representatives from local government, we had people with lived experience with mental health challenges, we had academicians, we had clinicians, we had faith leaders, and we just had folks who were wanting to make, in the words of John Lewis, good trouble. And so this group fundamentally altered our project. In working with the pastors and working with our steering council, they said, we actually don't want to train pastors in IPT. We're going to change the intervention. So I had to write a letter to NIH requesting to change that, and it delayed my grant by about a year. But the uptake of the new intervention that we did was so much greater than had we done with IPT. And so I am fundamentally here because of this group. So if we could see the next slide. And the report that catalyzed our efforts to address youth mental health was this report, Ring the Alarm, the Crisis of Black Youth Suicide in America, which was a report put out in 2019, 2020, at the behest of the Congressional Black Caucus, to really bring attention to the fact that Black youth have the fastest increase in death by suicide among any racial and ethnic group in this country. I do just want to acknowledge that my dear mentor, Dr. Nell Prim, who is here, and Dr. Joe were actually members of the group that wrote this report. And this work and my work in this space were also centered upon Dr. Powell, who will be speaking tomorrow. But when this report came out, in addition to the rise of mental health challenges that COVID brought upon in Harlem, where I live and work, our coalition really wanted to focus on youth mental health. And so we had been working primarily in faith-based settings. And so we partnered with an organization called the Hope Center that actually is a freestanding mental health clinic that was one of the churches where we first implemented the program from my K Award. They created a freestanding mental health clinic associated with the church. And so if we can go to the next slide, just want to briefly show a video that shows the integration of how we have worked together to address issues around faith and mental health through sports for youth.
Awareness Month, and this weekend, the Hope in Harlem Conference will encourage mental health care among young people through sports.
Jesse Mitchell is our reporter covering Harlem and shows us how an innovative program at a church continues to break the stigma for many in the community.
Casey Little started playing softball when she was 5 after watching Jackie Robinson videos online.
After that, I just fell in love with it. I just felt like I could be the first woman in MLB.
Her best friend lost his dream of playing in the NBA this summer when he was killed by another group of teens in the streets of Harlem.
I check on his mom, I text her. She told me I have a good day on purpose every day. So that's what I try to do.
Now a junior at St. Raymond Academy, Little is determined to look forward to competing in college, complete with mental fortitude, fortified at Thrive, the teen mental health program at First Corinthian Baptist Church's Hope Center Clinic, under the leadership of Dr. Lena Green.
We have good street cred, right, with our teens. They're telling their friends, hey, this is a safe space and a safe environment to talk about your feelings.
While teaching leadership skills and spreading the word about the 988 National Suicide Hotline, the clinic also conducts community assessments to gauge the growth of participants.
We get a sense from the parents, our children's grades have increased. We see that they come home more respectful. We see that they're asking for permission or they're willing and open to engage in conversations with us.
To expand the helping hand, the clinic's Hope in Harlem conference will bring professional athletes alongside leaders in medicine and education. One of the program's champions is Mount Sinai's Director of Mental Health Equity Research, Dr. Sidney Hankerson.
Men are more likely to die by suicide than women. And so our hope is that by partnering with sports, by partnering with the church, we'll be able to engage men and reduce stigma among men so we can save lives.
The conference will also connect the clinic with a coalition convening churches around the country that want to replicate this model. In Harlem, Jesse Mitchell, CBS News, New York.
And the Hope in Harlem Conference at First Corinthian Baptist Church takes place on Saturday from 10 to 1.
One of the approaches, Hope Center.
Okay, thank you. Thank you for that. So that is one of the ways that we have integrated the intersection of mental health, faith, and sports. The response from the community to the Hope in Harlem Conference was tremendous. And at the same time, we have to acknowledge that for a lot of youth, we hear this directly from them, and just, anecdotally, the data shows us that a lot of youth are not going to faith-based organizations. Churches for a lot of youth are not safe, often because of, conservative theology or perceptions around the theology around sexuality. And many youth are not going to religious institutions. And so we have acknowledged that, and we have partnered with the Hope Center to call that out and really address this notion of religious trauma, where faith-based organizations have been harmful to people with mental health challenges. But one thing that the kids did tell us at the intersection of engaging with the Hope Center and promoting mental health is that they love sports, and the Hope in Harlem Conference really brought that out. So I was fortunate to get funding for a project called Brothers Connect, and shout out to the earlier panel talking about social connectedness. This intervention is really built upon social connectedness and bringing people together. So working with Dr. Sherry Mollock, who's based here in DC, and Dr. Peter Wyman at the University of Rochester, Brothers Connect is really centered upon 4 cores, kind of kinship, balance, guidance, and purpose. And it's really an upstream prevention program. So those 4 out of 5 that are not actively having mental health symptoms, we're trying to get people before they develop those symptoms, bring connectedness together, and not just doing work with the youth, but also doing work with parents and with the coaches. Because we also know that coaches and families can be a tremendous source of stress for youth. So we really want to address the entire kind of social ecological network. And so, that's a little bit of the multi-sectorial work, that we're doing. And with Brothers Connect, we are partnering with multiple sectors, including government, corporations, sports leagues, and clinicians as well. Thank you.
Good afternoon. I apologize. I'm also losing my voice a little bit, so bear with me. Hard act to follow. Will say, used to go to FCBC when I lived in New York, knew about the Hope Center. So great to hear about that amazing work. And really appreciate the remarks and the insights from the other panelists. And I'm very excited to be here as well, and really appreciate the opportunity to talk to you about the work that we're doing at Google. Again, my name is Dr. Kamillah Wood. I am the clinical lead for strategies and partnerships for health optimization at Google on the health team. Before I kind of tee up what we're doing, I thought it would be helpful to give you a little bit of context of my journey and the lens to which I do this work. Obviously, me being a community pediatrician is very much anchored in that, but thought that would help to shape how we're seeing this work come to life at Google as well. So I've been practicing seeing patients for over 25 years, but over the last 10 years, I've spent my career working at the policy and systems level. We've talked a lot about upstream drivers, and for me, practicing in the community and having the privilege to serve, obviously understanding the role that non-medical drivers of health play and the health and well-being of the patients that I had a privilege to serve. One of my frustrations was like, man, I really don't feel like I'm solving a ton of problems here. I'm able to meet a lot of the downstream needs, but really we need to address the system level needs to change the community conditions. So I have experience working in the affordable housing sector. I spent about 3 years working directly with affordable housing developers, helping them to understand housing as a platform for health. ways that they can really leverage the work that they're doing to improve health from community health from their perspective. I've also worked in transportation, both at the federal level and then also in the tech sector. From the federal lens, looking at the intersection of health and transportation from healthcare access, but also economic opportunity and mobility. And then more recently, as I transitioned to corporate tech, I worked at Lyft, the rideshare company, and led their community safety policy work. And so understanding kind of the intersectionality of these pieces and now at Google. One interesting observation is that in each one of these sectors, they're all trying to impact the same end user, whether or not it's someone who lives in subsidized housing, someone who takes rideshare or takes public transportation, or somebody who's using search. And so for me, it's been really important to kind of engage at the system level to help to be a translator across health, right? So learning a lot of the language that they use, understanding where there's misalignment sometimes in language, but finding alignment not only in language and how we're talking about things, but how we're developing innovation. So I like to solve complex problems at the highest level possible. And so for that, that's kind of the lens that I bring in regards to the North Star, being able to kind of think about these things in a different way to not only just identify the challenges, but the opportunities and foster innovation. I still practice here in Washington, D.C. at Children's Hospital. I have the privilege of practicing at one of the network of community health centers. I practice in one in Ward 8 for those of you who are in the D.C. area and are familiar. It's a part of the city with some of the largest health outcome gaps. And as a general pediatrician, I run the gamut of your general childhood complaints. But obviously mental health definitely bubbles up to the top of that, right? And so, and I think post-pandemic or during the pandemic, that's even more emblematic, which I think has come across in some of the other panelist conversations. So that's everything from how we screen from postpartum depression to dealing with behavioral issues in school-age children to more significant diagnoses in adolescents related to anxiety and depression. So I kind of, for me, it's been important to always see patients no matter what I'm doing because it grounds you in the lived experience of the community. And oftentimes I have found in other sectors I've worked with, you can have this ivory tower component of we know what's best, we have the solutions, when really one, not even just partnering with community, but centering on community is important. And they are the experts at what they need, but also for me, staying grounded of serving in community. And that is a huge tenet for me into the lens that I bring to this work. So now I have the privilege of being at Google. I work on a health team that's there. Most folks don't know that we have a team of clinicians that run the gamut of all the subspecialties, pediatrics, obviously, to cardiologists. We also have clinical psychologists that we work with. And we work across our Google for Health initiative, which touches all of Google's products in any way that they might engage with health, with the mission of really ensuring that everyone everywhere can have a longer and healthier life. My team, I sit on a specific group within that team where we bring kind of the special sauce that makes that everyone everywhere possible, really understanding context. So to thread the needle on kind of this experience that I've had in housing and transportation is understanding the intersectionality of these systems and lived experience and how that impacts health and health outcomes. And so for us and our team, we know context is key, and we bring that lens to the work as we work with our other clinical colleagues and across the different product areas to make sure that that's incorporated and how we're building solutions and also how we're working with partners and community. So really, really fascinating work. You can imagine in this mission of helping everyone everywhere live a healthy and longer life, that mental health is a core component of that. And there's a variety of different ways that I think that shows up. At Google, we're very much committed to being a trusted partner for people who are looking for resources around mental health. So obviously folks like go to search and YouTube surfacing information and resources that are accessible for everyone. And, you know, partnering with large organizations like the National Academy of Medicine and the National Health Services in the UK. We do global work. I want to also emphasize we do a lot of US work, but obviously with a global lens and making sure we're able to surface information like what's the crisis hotline that you need, but also information to destigmatize against mental health. So we often say information is another critical determinant of health. And at Google, really being able to democratize that access through people having access through their phones and through search and all of that is a really critical component. I will say we are in a moment or in a time, and I came at the end of the last panel with generative AI being the latest innovation. And obviously, Google's no exception to that and how we're thinking about that work. And there's a lot of great work to be done there. And we think about doing this work boldly, but also responsibly and in partnership, right? So these are kind of our core tenets as we think about doing this work. And there are a lot of opportunities where generative AI can really begin to address some longstanding issues, but we want to be mindful that we don't also want it to exacerbate current gaps, right? So we think about that very critically. One area as an example, and I'm sure in a discussion can share more, but one example where generative AI can really play a role from our perspective is thinking about workforce development and access to services and care in areas, particularly in low resource environments. So earlier this year, we released a field guide in AI for mental health. You can find it at tasksharing.ai. We did this in partnership with Grand Challenges Canada, as well as the McKinsey Health Institute. And it's essentially an asset that walks through, here's what generative AI is, kind of gives you the lay of the land of what large language models are, but also here are real world challenges that it can solve, particularly around task sharing. So how do you do skill building training for mental health to train community health workers in the field and at scale and with efficiency? So this tool is intended to be democratized, kind of the access of how to use generative AI to meet your community's needs, with the key component of let's help humans do their job better, right? So this isn't about a replacement. It's about efficiency. It's about scale. How do you get more folks on board in community to be able to really serve through, again, community health workers or peer supports? And so this is an asset we're very proud of. I will say that the success and the cross-sector work that we're able to do is, again, anchored in that partnership and working with experts, working with key stakeholders who understand the needs of the community and how we can appropriately execute in what we're trying to do. And again, democratizing access globally to these tools. So very exciting work that we're doing, and happy to share more, but I really appreciate the opportunity to talk a little bit about what we're doing. And thank you for your must be voted.
What a terrific group, an inspiring group of presentations. I want to make sure that we have time for folks to ask questions of each other and also for the audience to ask questions. So I'll just ask a couple of questions here. And I think some of you spoke to this in your presentations, but wondering if you could share even a little more, whether it's something behind the scenes related to lessons that you've learned about effective collaboration across sectors, either the hard way or the less hard, the easy way.
Okay, let's see. I just make sure I turned it. I think one of the lessons learned working across sectors is learning the language of the sector, and really the school districts, the justice system, all have different language and different complexities to their systems, and being able to interface with them and learn the language and being a trusted stakeholder is really important, as well as understanding like their hours of operation, working at my colleagues here, working in schools or working at faith-based organizations, the day after service sometimes isn't the day to reach out. And so learning those things and working across the cultures of those different institutions has been a key part of being able to sustain relationships, as well as being compassionate and empathetic to as their systems are changing and challenged. If they're facing funding challenges, how do you walk alongside them and partner to meet those needs still? Because they do good work with families and the children that they're serving.
Classic. I think one of the things that I'm going to put it in present tense, continuing, learning, is that as mental health providers for so many decades, we've been screaming, we have a mental health crisis, we have a mental health crisis, and everybody's like, no, not hearing this. And now everybody knows we have a mental health crisis. We don't have to do the sell anymore. So how do we change our approach now that they're already bought in? And I think this is something that I'm really learning is, and picking up on your language about learning their language, is I think every sector has, and when we talk about funding, we talk about all these different things, every sector already has momentum. They've already overcome initial inertia on their strategic plan, on their financing, on their planning, on what they want to accomplish. I'm finding the easiest thing to do is to take what we do to them, what they've already planned to do, and show how what we do works. Whether that's housing, whether that's the education system, whether that's the healthcare system. We just had a great meeting with our health. So all of this, we can do this to change our healthcare outcomes. And we're like, exactly. Same thing with education. Same thing with jobs, and how do we recruit more businesses to the state by having strong mental health. Like, I think this is these folks, they really want to come alongside the crisis. And I'll go to the church piece yesterday. Okay, I did 3 church services yesterday. All right, this is a big, not me, well, it was me, but this is a huge mega church, biggest church in the state, 30,000 people, 5 campuses. And what this church did was they are all talking about mental health and said, we want to adopt this organization and make a dent in the mental health crisis. And so and we've already gotten $1 gazillion. We've gotten people volunteering out the woodworks who want to come, but we had to put it in language that they get because they already have the mission. So we just take what we do to the mission that's already in motion and apply the solution. And we found the same thing with the commissioner in child welfare and the head of mental health who's really wanting to do something. I said, hey, look, we can do these things if you bring the CapEx. And they fought the legislature for us. We didn't have to go to bring about this trauma deal that we've got now, $20 million from the state, $5 million from Congress. And we didn't have to fight the fight. What I'm saying is it's a lot easier not have to fight, to take what people are already motivated and running at with everything they've already got. They got their boards behind it. They've got everything. And we go, hey, we'll help you accomplish that solution that you're already committed to, as opposed to, hey, come to my mountain, come to my mental health mountain, and let me tell you how great. That's what I'm learning, is I need to change my narrative and my approach and meet people where they are.
I love both of those. I want to add, this is less from my Google experience, but when I worked in affordable housing and trying to work at the intersection of working with hospitals and health systems, and residents who lived in subsidized housing. A language example was we were having conversations, and from the health perspective, I kept talking about health equity. On the housing side, equity meant like credit, like what was invested. I mean, we did a convening where we did definitions. I mean, it can get what would feel very rudimentary and a bit parochial, is very much setting the baseline of communication to be able to collaborate. And the other thing, and this is more of a broad example of collaboration that I found was helpful as well, is kind of when there's any sort of business reason or kind of thinking about ROI and collaboration. So this was like 10 plus years ago, but one of my tenants was in the affordable housing. We were doing a lot of service-oriented work around health. But to me, I was like, if you just build more affordable housing and people can be stably housed, the services come after, but we just need more affordable housing. And so there were a lot of efforts to try to work with hospitals and health systems to understand if they invested in the building of affordable housing, particularly in the communities to which they serve, that helps their bottom line in regards to addressing kind of the chronic medical conditions from being unstably housed. And so connecting that from a financial, not to distill people down to numbers, but because of how systems work, some of that is valuable too. And so it may not apply to every sector, but it's to your point of kind of finding that moment of alignment. There was a lot of work that came from other organizations as a result of that. Bon Secours in Baltimore, if you're familiar, has done a lot of investment. Nationwide Children's in Columbus, Ohio has done a lot of investment. And it kind of was trying to get to that community benefit that hospitals and health systems do around health as well. So just another example, maybe not so specific to adolescent and youth mental health, but just kind of that idea of trying to triangulate areas of synergy to really collaborate for innovation and solving both sectors' issues of trying to meet the needs of the community.
I'll just add, and I love that, thinking about what's the ROI, because I think some people think that, well, if you build it, they will come out of the goodness of the heart, but not necessarily. You really have to think about what's in it for that partner. I can share some tough lessons learned from my experiences. So, there were instances that we did not engage sector partners early enough in the process. So I would encourage folks, if you're thinking about doing any coalition building or doing multi-sector work, think about at the outset all of the sectors that you may want to engage them early, because there were instances where I did that late, and it was really, really difficult to then engage those folks in the process. That would be number one. And number two is just trust the community. Trust the community, trust the community strengths, trust the community assets. I cannot thank our community steering council enough. FCBC was one of the churches where we did, work for my first grant, and Pastor Waller was like, I don't have time to be seeing more people in counseling. So he was one of the ones who was like, we need to do something that can be scaled and that's for more people. And the work that we did with his church ultimately led to the Hope Center being created. And so it's just really tremendous. And for me, as a scientist, I was stressing out because this is what I said I was going to do in the grant. What are folks going to think? I had to change everything, but trust the community. So that would be my, trust the community.
Love that. And yeah, I like these mics, but some of them work better than others. Just to add to that quickly, I think just communication is so important. And the more we've worked with schools, I think the more we've had really sort of nuts and bolts conversations up front. If we partner, what's that going to look like specifically for you? What's it going to look like for me? Is this a good fit? And sometimes it's not a good fit, but I think those discussions are really helpful for knowing that. And then I think it makes the partnership a lot stronger going forward.
Before we open it up to any of you have questions for each other
I have one question, I think, about the task sharing AI and that tool. I was just thinking that's such a great asset. One of the challenges in our community, though, is also figuring out the right tools for the literacy level of the population. And so is there any accommodations in that regard? Or is it also in a video form, or other action items are broken down?
Are you talking specifically about that asset itself, or just in general on how we do? Sorry, I just want to make sure I answered.
Oh,
okay. I think the task sharing is there. I think there are some videos associated around some of the use cases, but don't quote me on that. I was going to say more so that health literacy is a big component of some of the work that my team does. So when we're thinking about context and we think about personalizations, it's kind of meeting people where you are. So I will say that is kind of a part of our health work more broadly. A real tangible example of where that shows up in our product right now is that if you use the Google app on your phone and you go to any websites and you highlight the information, there should be a pop-up that has a link that's called Simplify, and actually simplifies all the information without changing the actual nuts and bolts of the information to kind of help simplify everything from financial kind of information to health information. And so to your point, probably didn't answer it fully. The task sharing document is kind of one example of kind of how we see Gen AI being democratized to empower communities to kind of build what works best for them and understanding how to figure out how to use the models in that way. But I also wanted to just call out that health literacy in general is clearly important, particularly as we're thinking about building for everyone everywhere on their own terms, just meeting where you are from your kind of literacy moment. And so that is an important part of our work as well.
Great. I kind of want to ask Sidney how he got to do a PowerPoint. I heard there was a meeting and we said, well, there's no PowerPoint. Do desktop PowerPoint like nobody. A little Rob, Sidney. Yeah. I just had to say that. How do we get it out? Let's try to get that out, Sidney. All right.
I did let it know. I was like, good to go.
Questions from the audience? Yeah.
The next one. Well, thank you for all the speakers and panelists. My name is I'm Dr. Sidney. I'm a research fellow from Johns Hopkins Bloomberg School of Public Health. I really like the topic today is about the multi-sector because before getting back to academia, I've been working for Morgan Stanley for 12 years in investment banking. So I have a question for Dr. Wu, if I may. That's also related to the last panel we have. I remember Dr. Wu raised an important point about in a lot of research in the healthcare area, mental health, or the non-commercial related behavior research, or even some clinical interventions. They are actually very critical need to get the data from the internet companies, social media companies, or even the online gaming companies. However, is there any practical case that we can make this happen, or if they are something we're doing right now towards the best practice? If you could share with that may be very helpful. So in basic, how to acquire the data or share the data between the internet companies and the scholars here, as everyone's sitting down here.
That is above my pay grade. Don't have an answer for you. I think I will say that, access to data, and we know, I will say broadly, data sharing has always been an issue, and often across sectors, data sits in very specific silos, right? And being able to share that across has always been a challenge. I'm not diverting your question by name. It's literally above my pay grade, so don't have an answer there. But I will give you an example that outside of my Google space, sharing, one of the challenges that we found in the housing sector was also kind of the data sharing and the regulatory pieces of HIPAA, particularly around health information, right? And so these are sometimes the different friction points that have to be navigated, obviously, and being able to do that. My point is that I think, short of the technological piece related to data sharing, I think data existing in silos is a chronic problem across sectors that oftentimes can be a challenge when it comes down to collaboration, but not something that's impossible. I will say often in my previous work, people would use HIPAA as a sole example of like, oh, we just can't share data. And then it's like, no, you can, not all data is HIPAA, not everything. And that doesn't mean we're being flippant about it. You want to be very mindful about privacy and security and all those pieces. But I think in general, because of the siloed nature to which how our systems work, data sharing is very challenging in general. So apologies, I don't have a better answer for you, but just insights there.
If I may have a follow-up question.
Yes.
Practically very straightforward. So if any of the scholars, scientists sitting down here today will generate a proposal without touching the confidentiality part, should we deliver this Google or internet company related proposal to anyone from the vehicle you're working with? How do we make that happen?
So we do have a lot of Google.org is kind of our nonprofit arm of the company, and they will often have a call for proposals for a variety of different research opportunities where there's opportunities to collaborate internally with Googlers, as well as fostering different thesis around a variety of different health issues. Health is one use case. Obviously, there's others. But there are definitely opportunities for research, and oftentimes our Google.org arm of the company will help to facilitate that. And they usually will have funding mechanisms and things around priority topics or priority issues that the company is looking into. So there is infrastructure there to explore, to apply for those research opportunities for sure.
Google.org, correct?
Yeah, Google.org.
Thank you so much.
No problem.
Some questions over on this, and just to remind folks, I think there's another one here, but we also have the traveling microphone for other questions.
First of all, I just want to say thank you for sharing your insights on multisectoral collaboration, which is where I think our field really needs to pay more attention to. I was curious about if in your work or research you've found instances where the interests of one sector fundamentally are incompatible with the interests of another. Something that has come to mind throughout the day has been our discussion of generative AI, which we've talked a lot about the possible benefits and applications to intervention and services. But on the other hand, there's been discussion of the environmental impacts of generative AI. And we've also talked a lot about climate change and how that impacts mental health. And so these sorts of contradictions, I'm wondering how you've navigated them in your work and research.
Except for me again. You all want to ask questions, I don't get paid to, and I'm too yeah. Obviously sustainability is something that comes up, and the company has, done some work in that space. To your question of when there's been contradictions, or maybe where there's been differences of coming to alignment around where you can have mutual impact. I will say, and I've been at Google now for just a year and some change, so I haven't quite seen it there yet. I hate to keep pivoting to my other work because there has been some really good examples, but I often find that in the health and housing world in particular, there was always a challenge of people kind of chasing the money. And so housers had this idea that the health system had a lot of money they could tap into, and getting that clarity around misalignment of what that actually looked like and sometimes cause friction there. So again, I think there's been examples that I've seen it there. I think there are always going to be polarities around work, around impact, and kind of what are the trade-offs there. And I think, at least in our team, we're very mindful of how we do the work. And again, for my group in particular, thinking about context and how the complex interplay of all these pieces. But I don't know that I have more of a specific example in that way, but really appreciate the question. And I think, we're at a fast moving pace with innovation, and trying to keep up with both the positive and negative externalities are important, and it's something that the company takes seriously.
I would also say from a non-AI perspective, I think there are some pretty deep tensions that exist across sectors and, really raise a lot of challenges for sustainability. So for example, schools have, they have so many mandates about what they have to get done. And those are often at odds with some of these other, integrating mental and behavioral health within schools in various ways. In my experience, principals are often really excited because they see a need and they want to offer a range of options for their students. But it's practically speaking, financially, logistically, and even just in terms of what they're allowed to do, there are often just a lot of constraints. And I think that is a challenge. And these can also change from year to year, as well as the funding. So I think just having, it's made me think a lot more about policy to get certain things in a school district's line item budget and part of their mandate explicitly, so that it's not just like, oh my God, and I'm going to try to do this extra thing on the side that I'm not even it's not even part of what I'm supposed to be doing.
Great examples. Any other ones before we move? I know looks like we have a couple more questions.
Can we go?
Yeah.
Hey, I'm Shami Fineglass. I am with Manat and also been in the government and in the private sector. So first off, on your data sharing question, you can find me afterwards. Take a look at the FDA evidence accelerator that Amy Abernathy had put together during the pandemic. Many of us had worked on that with her, but there's a nice example there. But for you guys, so how do you scale these ideas? The one thing we don't want to leave here without knowing is, what is that one thing you want us to amplify? Or what is the one thing you need help? John, you are just nodding. You were just
Thank you, Shami.
and giving me an evil eye on the side.
No, it is the right question, and it's a word that frankly I've had to integrate into my vocabulary over the last several years. Scale is not a word that we typically think about and say in Mississippi. I'm just going to name that. And I have found, particularly this work, and we three of us uncoordinated talked about hope, that if there's one thing that we can scale, that I am convinced we can scale, and I believe, and we talk about some of the downsides of technology, that technology has the ability to do, and schools with all the X required minutes that they have, and we found time in STEM class and et cetera to make it part of academic hour, but also I think I want to see hope scale, be democratized, be available to every kid in the world, because I do think it's the one thing that can change whatever the outcome, whether that's cancer overcoming or whether it's academics. Hope is actually a better predictor of your college success than your ACT or high school GPA. The opening piece in the invitation was what other things might we measure? Hope. It's not a feeling, it's a science, and I do think that it is one thing that we can do, because the workforce issues, at least in my state, are not changing. And so I can't say let's scale more mental health because we don't have the people. But what I can do, and I are doing, and I was in, y'all might have saw in the national news, we had 3 mass shootings 2 weeks ago. Over 20 people shot in one spot. And I went to that school district and met with everybody there in Leland and then in East Jasper. What's the one thing I can equip a school with nothing in the Delta with? I can't give them a psychiatrist and a pediatrician and a mental health provider, and I can't do that. But you know what? In a day, after doing a lot of crying and a lot of sitting and a lot of all of that trauma work with them, I equipped them with hope. And how when those students came in the next day, they too could equip kids with hope. So I'm giving my biased thing about the scale. What I think about, I think my brain first goes to all the 1,000 barriers we have in our state and how hard it is to scale anything. And then I have learned to say, well, how do we just move around that with things that we can get access to with technology and with things that are scalable like hope? And that's my, unintended, that's my hope, Chami, to be able to scale that.
I do think it's like the question of the hour, right? And we and I wish I had a clearer answer, but I think that policy is key, and also framing the needs of young people in ways that can broadly resonate with policymakers, politicians, education leaders, families. I think there's, at this point, a concerning trend of people questioning the need for addressing young people's mental health, and sort of questioning some of the evidence-based approaches that have shown to actually benefit young people. So I think part of it is how can we frame these sorts of efforts in ways that are broadly going to resonate. And then I think without, the funds, the infrastructure, the training and support, it's not going to be sustainable. So for that, I do think we need budgets to include this. It needs to be included as part of a school's mission, speaking from the perspective of schools, as part of the mission, and, really equipping principals to have those resources.
I think for me, I do think we have to leverage technology. I mean, I love what John has talked about today. The ideal of screening for hope and scaling hope, I think, is tremendous. I have had conversations with YouTube about how do we work together to scale some of the things that we're doing in faith settings and in youth sports settings. I think in particular, when you think about high school students now, right, and the pressures of potentially getting money in high school and college through NIL, name, image, and likeness, it's tremendous. And it causes tremendous frictions at times in families, because families think, well, this is going to be our ticket out. There's a lot of pressures on the kid, and it's unregulated. At least in college and in professional sports, there's some regulation about what you can do, But in like the high school, like it's not. There's nothing. And so I think that for me, that's where I'm going to hone in is that just that age group, because I think if we can get kids to not just be in organized sports, just be physically active and embrace the social connectedness, build on the strengths of communities, right, and leverage technology. We literally could do that around. And I think figuring out how to leverage technology with this is critical to scale.
I want to echo what John was saying, because I also heard that we can scale community, right? John showed up and was in relationship post-tragedy, post-trauma, and that expertise lies within community, right? There's communities right now leveraging the relationships they have. As Dr. Hankerson has said as well, that you can rely on those relationships as well. So that's the other part of scalability. Those communities and the community knowledge and expertise to lean on that is scalable. And so sometimes funding dries up, but the community still holds this wisdom that once the funding comes, they know where it needs to go and how to use those resources. So I think that's the other part.
Well, my question is for Sidney. I had a question to you since you work with youth in sports. In your experience and in your field, how do you go about mitigating the toxic sports culture, especially in that age group? Because recently I went to my little brother's high school football game, and I forgot how horrible these coaches talk to these kids. I played football before, but that was years ago now, and it reminded me like this. It is very much normal practice for football coach or sports coaches in general. As I feel like, especially when it's male-dominated like sports coaching, the way that they treat and talk to their athletes sometimes is abysmal. So you're in line of work. How do you mitigate that toxic behavior and that toxic culture?
I think that's a wonderful question. The way that we're going about it is, one, we're calling it out. We're acknowledging the fact that a lot of youth mental health challenges emerge from the dynamic with the coach. So number one, calling it out. Number two, calling them in. So involving the coaches and requiring them to get trained. I have helped coaches get connected to therapy because a lot of them have trauma that they have never processed that they are taking out on those youth. And so I think creating the spaces where they understand what the therapeutic process is like, then changes their language and then changes the environment that they then create for that sporting environment. And without that kind of lived experience of going to therapy, it can be very difficult for someone to say or encourage an athlete to go to therapy themselves. So that's been the ways.
I love that. I probably like you played everything growing up, played through college, had a lot of bad coaches. And my sense was they're always doing to the athletes what was done to them.
Absolutely.
And one of the beautiful moments I've had, and had a great relationship since when we were at that high school. We had a little meet me at the flagpole moment with the community after the day, and the high school coach came up to me and tapped me and said, "You got a minute?" I was like, "Yeah." He's like, "What do I do?" Well, we got a game Friday because the shooting happened at a big pep rally for the previous week, and whole community, and 4 or 6 gunmen just opened up into this group, and he's like, "What do I do?" I said, "Well, let me ask you a question. How many of your players have a dad in the house?" And he said, "Maybe 2. But you're the only model these guys are going to see. And to be able to see you cry, to be real, to pull them into a room and have an honest conversation." And this guy's eyes were like this. And so we had to kind of walk through what that looks like. So this is how you're going to have to lead because they've never seen it. It never had it. So I love your question, man, and I love what you're doing, man, because coaches can be a pathway to these men, and the presentation that Sean you made earlier and the suicide work you've done with Black men. I mean, this is a beautiful avenue, and so I appreciate the question and the opportunity to kind of intervene in a different way with kids.
I appreciate your responses, and I appreciate what y'all doing to uplift the community. Thank you.
I have time for one more. I actually don't have a watch. All right, so it's hopefully not a hard question. My name is Judy Bass. I'm faculty in the Department of Mental Health in the School of Public Health at Hopkins. You've presented these great examples of intersectoral work. And one of the things that I've been thinking about is how do we learn from one another? And what are the opportunities for converging and learning? And so you talk about the cross-sectoral work and the projects of learning from one another in that zone. How do we break out of our presenting at our conferences of our professional groups to actually collaborating and learning from one another who are doing these works across sectors? How do you learn from one another outside of these convenings? What are the venues? What are the mechanisms? What are the ways that you've learned what each other are doing and what different groups are doing that are outside of your professional networks?
Yeah, I'll say one example is in Memphis, we have a conference called the Psychiatric Advocacy Collaborative Team Summit. And it's designed for just that purpose, to have intersector relationships convening around well-being and mental health in youth. So we offer CME, CEU, and CLE for policymakers to also be in the room. But we have youth panels as a part of the programming. We also have an intersector panel with people that are in nonprofit areas, faith-based organizations, but really thinking about having convenings that are more multi-sector, and especially if it's in a region that breeds what we were talking about in terms of community and relationships. So when you're calling and referring to another entity, you have that relationship with the other organization to say this would be a good fit, or I know who I'm calling and referring the family or youth to interact with. And then they can also give feedback in those same spaces to say this is working or this isn't working. So that's one way we're talking.
I think for me, I've tried to how do I own whatever the problem, the question is, because I can't get everybody else to do whatever I want them to do. What do I do? So what I do every day, and I happen to be fortunate to be in a position as a CEO, and when I can call somebody, they'll have a meeting. So I'm very blessed, and I get that. I'm fortunate that way. So I'm very intentional to make sure I'm having lunch with the commissioner of X, Y, Z, A, B, C, all the way down, legislative leadership, executive branch, all the time. Relationship. Because I have found that if I can take time, again, not to tell them about my world, but to listen to theirs and understand what's on their heart and what's on their mind about what they're really interested in solving, that we can bring something together, and then they're excited about the work. And so the way that we're doing, and I'll give you a case example. Last week, the State Department of Health, the state health officer, convened a meeting because our state was 50th on health outcomes again. So he called all these multi-sectoral folks to the table, the heads of every state department, I'll fill in the blank, and then us and the head of the medical center and whatever else. And so everybody's presenting around their work and defining ways that we're going to run at this one problem together. So define the goal together of a health outcome to not be 50th. Go root for us. We're going for 49. We can do it. We can. Hey! I got a tout. Have y'all heard about the Mississippi Miracle in the education? We've gone from 49th to 9th in the country on our 4th grade. And if you adjust for economics, we're actually #1 progress in all the nation in the education. And it's not really the Mississippi Miracle, it's the Mississippi Marathon. We've been running hard at this through doing this multi-sectoral work, and we think we can do it on healthcare too. So we're talking about diabetes and obesity and et cetera, John, what can mental health do about that problem? That's the conversation we had last week in the health officer's office with all of us around the table. So I think that's how we're trying to really hack at these problems differently, get out of our silos, build relationships, build a lot of trust, and take some risks to do something together that maybe we've never done before.
I think I've learned a lot about multi-sector collaborations from being in touch with community partners in Baltimore. Baltimore is an amazing city. I mean, there's so much going on. And I think just having community partnerships that are consistent over time and hearing about what folks are doing and how they're able to connect. There's an organization called Baltimore's Promise that's a collective that does a lot of intersectoral work. We were fortunate at the Center for Adolescent Health to get connected with work they were doing to bring together the Mayor's Office of Employment Development with city schools and with employment training and employers to create sort of viable pathways to career training for young people who were graduating high school and were not intending to go to college, and to wrap mental health and legal supports within that training. And so, lots of different folks came to the table with that across sectors. The incredible work of youth-serving organizations at the grassroots level. Many of them are connecting with organizations and having young people sort of do trainings and share their wisdom in other kinds of settings. And there's a program, the Healing Youth Alliance, that's training youth ambassadors in mental health who are connecting with others. So I think just sort of being connected with what's happening locally has been tremendous.
Yeah, and similar to Alicia, we have a conference in New York called Mobilizing for Mental Health Equity. That is, across sectors. We invite clinicians, policymakers, Justice Department, and really try to share what we're doing individually but collaboratively. And then one thing we're going to do is give everybody the option to have their emails be shared so that we can spread the word, together and with each other, and love to connect, with you, so we can do that here. But I think those kind of things can be really helpful.
Yeah, I think plus to what folks have said, I think in previous avenues of work is really not waiting for the venue to be creative, but creating the venue and inviting people to the table of the solution we're trying to build. And there's often a curiosity, and the question is just waiting to be asked. So in previous work, kind of figuring out, there was a meeting once where we were trying to impact health and housing at a top level. So it was like, I wanted to invite the state housing authority, the state Medicaid director, philanthropy with the affordable housing developers. So instead of waiting, sometimes for the other venues to show up, creating the space for the folks to come together and say, we're all trying to solve the same problem has been helpful. I think very much akin to what other folks are saying there. And then letting those connectivities of driving the work that the org I was with at the time was trying to do that. But then there's that micro connectivity of other folks connecting and almost having that be a catalyst, right? And kind of letting that live within the ecosystem where hopefully these ideas, the idea of collaborating will have some durability over time. I think there's also kind of the playing the long game of being able to constantly iterate of getting together and having these discussions over time and finding creative ways to do so outside of like APHA, which I'll be at next week. And, all of those kind of venues is obviously kind of making those connections and finding other spaces that are unique.
Yeah, so I think we are about out of time, but thank you guys so much for being here. I think just a couple of the themes that I heard was really engaging with the natural supports that are available in the community, but I also love that people recognize when those are when there are challenges and continuing to engage. But for example, the example given about coaches and churches, so going in with your eyes open in terms of making sure that we're appropriately engaging natural supports. I think making sure we don't forget about the family. I think that was something that you talked about with the work is super, super important. And the role of both the youth and community input. And then I think this issue of translating and how some things don't make sense to other systems. And so the important role of translating what you're doing to make sense to other systems.
I want to thank this panel, and I want to thank all of the panelists that we've had today. It's been a fabulous day. There's so many people to thank for this day, and we'll do more comprehensive thanks tomorrow. But just to start, thank you, Sarah, for hosting us today, and I want to take a minute because I want to note that this event for us is a wonderful opportunity to convene all of you to talk about adolescent mental health in the context of the Second Lancet Commission on Adolescent Health and Wellbeing. And it's also a chance for us to really kind of launch our Johns Hopkins Center for Global Mental Health, of which adolescent mental health and this idea of really global learning to inform what we do wherever we may be is a central theme. And so we're happy to invite you to celebrate with us with the reception that comes after this